And we move on to Professor Bent Ejlertsen, who doesn't need too much introduction. He's a professor at the Rigshospitalet in Copenhagen and for the Danish breast cancer group. And, you know, we are all jealous because the Danish have this wonderful treasure of population-based information. And I think that that's also the topic of your presentation today. Bent, please.
Thank you so much for this nice introduction. I hope my slides is in here somewhere. Yeah. Yes. And these are my disclosures. I just want to start out reminding you that actually the DBCG meta-analysis have proven that all patients have a relative benefit of chemotherapy, irrespective of age, nodal status, size, grade, ER status, or use of tamoxifen. So the absolute gain from chemotherapy will depend on the absolute risk, which for ER-positive patients are the risk remaining with endocrine therapy. And low risk implies low absolute benefit, but can we identify these patients who does not need chemotherapy? And that was the scene when we made our cohort study. It's a population-based study, including on a nationwide basis, patients diagnosed between 2000 and 2003 who were treated with 5 years of endocrine therapy without chemotherapy. We had a prospectively defined analysis plan in order to validate Prosigna as a risk predictor, not only in node negative, but also in the node positive subset. And we looked both at disease-free survival at 5 years and at 10 years. The endpoints were time to distant recurrence, and the secondary endpoints were overall survival and time to any recurrence. And as you can see on the right side hand of the slide, we started out with a population a little less than 3,000 patients, and only in 231 we had no available tumor tissue. The analysis of the Prosigna passed the quality assurance in a really high number of these remaining patients, and we were able to include a little above 2,500 patients in the analysis. So on the left side, you have the patient selection criteria, and what you need to focus on is that these were postmenopausal patients, 50 years or older, who had an ER-positive and a HER2-normal tumor, and one of the following risk factors. These were not low-risk patients, but had either a tumor size of 2 centimeters or more, 1 to 3 positive lymph nodes, or a grade 2 or 3 tumor. And they were all allocated to 5 years of endocrine therapy. And in the patient characteristics, you can see that actually a high proportion of these patients were lymph node positive, had a relatively large tumor size, and were with grade 2 or 3 tumors. And here you have the continuous Prosigna score against 10 years of distant recurrence. And I think this is the most beautiful graph from the publication, showing that you can actually, within these patients, find a low-risk group, but you can also differentiate between patients with 0 to 1, 2, and 3 positive nodes, reminding us all that this is not only about genomic risk, but also about clinical risk. So this was only able due to the large patient numbers and support the use in clinical practice. Here you have the curves on the three raw groups, with low risk being between 5 and 3.3% among patients who have either node negative, 1 or 2 positive nodes. There are none of the patients in the low risk group among patients with 3 positive nodes. But still, even among those with 3 positive nodes, you can discriminate between the intermediate and the high risk group, and in all 3 categories you see a nice split between the high and the intermediate risk groups. Here you have the same exercise by splitting patients on luminal A and luminal B cancers. The numbers are slightly smaller because we have excluded HER2 enriched and basal-like tumors. And again, you can see that with 0, 1, 2, and 3 positive nodes, luminal A cancers at 10 years have a less than 10% risk of distant recurrence. Here is the multivariate analysis for distant recurrence, and what I want you to emphasize is that there is a clearly and significant split not only between the low and intermediate, but also between the high and the intermediate raw risk groups. Not only between 1 to 3 positive nodes, but also between those between 0 to 3 positive nodes. And you also have a highly significant split between luminal A and luminal B. There were patients who were not included in our cohort study, but luckily our colleagues in Norway have looked at the groups that we did not include. So they included premenopausal patients, and they also included patients who not received any adjuvant therapy. And here you have the results regarding the raw risk categories, and what you should emphasize is that even in the group who received no adjuvant therapy, the raw score is able to actually discriminate between the 3 raw categories. But one thing is prognosis. What about prediction? And we actually wanted to look at the possible predictive value of Prosigna, and went back to the first trial done by the Danish Breast Cancer Cooperative Group, where we included premenopausal patients who either had node-positive disease, a tumor size beyond 5 centimeters, or deep invasion, but were without distant metastasis, and all had mastectomy and radiotherapy. And we randomized these patients to 4 groups, either no adjuvant chemotherapy or adjuvant therapy at all, levamisole, or to cyclophosphamide given orally, or to CMF. This trial was stopped early for safety reasons, and it was actually because of the levamisole treatment who introduced thrombocytopenia. Due to the early safety analysis, we closed the control arm arm and the levamisole arm, and continued randomization to cyclophosphamide versus CMF. And it'll appear in the next slides as well. So here you have the data from the original trial, disease-free survival on the left, and overall survival up to 25 years on the right. And as you can see, we actually, even though the trial was stopped early, were able to demonstrate a significant effect of both cyclophosphamide alone and of CMF, and it transferred into a survival benefit. It was easy to do trials in those days. We then went back to the tumor tissue, which actually for a large proportion of these patients had been stored at the different department of pathologies. And on the left side, you can see the consort diagram. And on the right side, I have included the diagram showing the disease-free survival in patients who received no adjuvant treatment. Again, it's important to emphasize that these patients were high-risk patients, and it is, of course, reflected in the patient characteristics, with the majority of these patients being node positive, having a large tumor size, and having a high grade. And here you have the results regarding the Prosigna intrinsic subtypes. In the left on the top, you have luminal A with only a very small benefit, or at least no significant benefit, from adding cyclophosphamide-based treatment. But on the bottom, you can see a large effect derived in patients with a basal-like tumor. Patients with HER2-enriched tumors derived no benefit at all from cyclophosphamide-based chemotherapy, and patients with luminal B disease were in or had an intermediate benefit. This is the multivariate analysis shown as a forest plot, and as you can see, the Prosigna intrinsic subtypes actually were able, highly significant, to discriminate between the benefit of cyclophosphamide-based chemotherapy in these four subgroups, both for disease-free survival and for overall survival. We were unable to show a benefit for the raw scores. But we made an exploratory analysis with a different cut points, just to emphasize that patients, when you put together the low and the intermediate risk group, actually may have some kind of a signal. Our Canadian colleagues, when looking at the MI5 trial, actually have data that is very interesting when combined with the data from the 7B trial, showing a benefit primarily in those patients who have HER2-enriched tumors, and no benefit at all in basal-like tumors. Here again, the multivariate analysis, and they included as well HER2 as for comparison, and they previously have shown a highly significant benefit in patients with HER2 positive cancers and no benefit of including an anthracycline in the HER2 negative subgroup. We have set out to reproduce these data, and I have used the DBCG 89D trial, which included 3 groups of patients. Group A, premenopausal high-risk, node-negative patients. Group B, premenopausal node-positive tumors. And Group C, postmenopausal patients who were node-positive and ER-negative. And they were randomized to 9 cycles of CMF against 9 cycles of CEF, but a relative low-dose anthracycline. And on the right side, you see the disease-free survival from the primary analysis of that trial, showing a significant benefit for CMF compared to for CEF compared to CMF. And we have now collected tumor tissue from 686 of the 962 Danish patients included in the study, and had performed the Prosigna test. The primary endpoint of this analysis was time to distant recurrence, and secondary endpoints were time to recurrence plus overall survival. And we could actually confirm a substantial benefit from substituting CMF with CEF in patients with a HER2-enriched subtype, as previously suggested by the MA5 trial. So in conclusion, in a real-world setting, Prosigna reliably identified a significant proportion of patients with 0 to 3 positive nodes who may be spared treatment with adjuvant chemotherapy. Among high-risk premenopausal patients, Prosigna suggests in the DBCG 77B trial that breast cancer patients with HER2-enriched and luminal A intrinsic subtypes may derive very little benefit from adjuvant cyclophosphamide-based treatment. In the MA5 trial, however, the investigators found that premenopausal breast cancer patients with HER2-enriched intrinsic subtype might derive a substantial benefit from anthracycline-based adjuvant chemotherapy, and data from our DBCG 89D trial support this finding. Thank you.
Thanks, Ben, for an elegant presentation, particularly on also these final suggestions that we might be able to select the type of chemotherapy in the future. Do you also think that this would work for selecting a taxane for specific patient groups?
I'm not sure about that. Primarily, data suggests that taxanes actually may work in all 4 subtypes.
Yes. Okay, questions from the floor? If not, maybe I can ask a final question. I mean, you are using the test, if I know correctly, on a nationwide basis.
Yes.
How does this work, and how do you use intrinsic subtype in guidelines or in the actual population treatment decisions?
Yes, we have introduced Prosigna nationwide in Denmark for patients with an intermediate clinical risk if they are postmenopausal and have a ER positive and HER2 negative disease. So only in that subset. And if patients have a low clinical risk, they will receive endocrine therapy alone. In the intermediate risk, patients with a luminal A cancer will receive endocrine therapy alone, and patients with luminal B cancer will receive adjuvant chemotherapy, or at least be offered the choice of it.
Which is quite similar as what Eva told us about the policy in Madrid. Okay, thanks a lot, Bent. And can